The process of applied functional science is the transformation of the notion into the motion.
From the Gray Institute, this is the Gray Institute podcast. Gray Institute is internationally acclaimed for its innovation, development, mastery, and delivery of applied functional science, AFS. AFS is based on scientific truth, not theory, of how the human body moves in all three planes. AFS allows movement professionals like you to apply the best, most effective, and most efficient movements to any individual based on specific needs and goals. For 40 years, through training, education, and mentorship, Gray Institute has equipped over 150,000 professionals with comprehensive knowledge in the principles of applied functional science, AFS. Whether you're physical therapists, personal trainers, athletic trainers, chiropractors, strength and conditioning coaches, physicians, physiotherapists, occupational therapists, osteopaths, physical therapy assistants, or kinesiologists, our goal is to help you become the go-to movement professional.
Gray Institute community, welcome to another webinar. On behalf of Gray Institute, I simply want to welcome you to this webinar entitled Low Back Pain, Causes and Solutions. The low back certainly gets a lot of press, and rightfully so, but here's the catch. If the low back is in pain, 99.9% of the time, it's not the low back's fault. In fact, many injuries of the body can fall into that category. It's not your fault. In order to better protect the low back, in order to protect the rest of the body, in order to empower the low back, in order to empower the rest of the body, we really need to know how the body's put together, who's zooming who, and how we can understand and apply that information, not only just for the low back, but also for the rest of the body. So in this webinar, Dr. Gary Gray is going to be delivering gold when it comes to the low back and the rest of the body, not only based on his 45 plus years of experience, but understanding, of course, applied functional science. What does the science say, and how do we apply that not only for the low back, but strategies for the rest of the body as well? And that's why here are the three big rocks that will be covered in this webinar. Number one, chain reaction biomechanics of the low back, the crossroads of the body. Number two, strategies for prevention and training of the low back and the rest of the body. And big rock number three, strategies for assessment and treatment of low back dysfunction, acute low back strain, spondylolisthesis, and degenerative disc disease. As you embark on this journey in the next hour through this information, just sit back, relax, and enjoy the information, and understand to understand the low back is to understand the rest of the body.
Thanks, Dougie, for that thoughtful introduction, but thank you mostly for you watching this webinar. The understanding of the low back and us taking care of the low back is certainly a challenge. I remember years ago I was invited to speak at a seminar called The Challenge of the Lumbar Spine. And I can recall one of the participants, very kind, came up to me and says, I've never been to a seminar where you didn't really talk about the part. In other words, she said, you talk more about the rest of the body and then how it related to the lumbar spine. And she also says, but it's a challenge, isn't it? And I said, well, it's a challenge. And for my entire career, it's been a challenge. But we're just going to unwrap a little bit of what we call an understanding of approaching low back pain through applied functional science, of course, what we call AFS. And I'm glad you're along with this journey. Before we go deep in anything, we like to kind of step back and just go, wow, what's going on here? And when you step back and look at the low back, you go, you know, there's not much we do that doesn't influence the low back. That's why in AFS, we call it the crossroads of the body. As soon as I move my hand, boy, it goes right through the low back. As soon as I take a step, that goes right through the low back. And therefore, that's a critical part of the body that you go, wow. Now, another thing when we step back, if you've been in the industry for any length of time, we realize a lot of people have low back pain. Well, those two things together shouldn't kind of confuse us. It should be, yeah, I can understand that. Another thing we have to ask is, why do so many of us have back pain, and why, even though we can temporarily make it feel better, why does it come back? Why does a lot of the research say that, boy, even if you have really good treatment, that there's a good chance that the greatest percentages of these come back? And I think you already know, if you've watched any of the other webinars, is that it probably has to do with not just treating the symptoms, but treating the causes and the compensations. The other thing we realize in applied functional science is that for us to really understand the part, we have to know the part as it relates to the whole, and the whole as it relates to the part. And we have to know who's zooming who's influencing who. We have a saying in applied functional science that we believe 100% of low back pain has nothing to do with the low back. Here's what we mean when we say that. We don't believe the cause is in the low back. We believe something in the body causes the low back to work dysfunctional and tears part of it down, and then you have symptoms in your low back, but we shouldn't be spending a lot of time at the low back trying to treat those symptoms, knowing that ultimately if we treat the causes effectively, those symptoms have a great chance of going away. So I'm glad you're joining us, because we're just going to kind of have fun talking about and understanding this and get us kind of kick-started into ultimately understanding the strategies, and then looking at some common entities that allow us to say, wow, I never thought about that. That's a really cool strategy for that particular problem, that particular diagnosis, that particular type of pain. When we talk about anything, we always have to be what we call context dependent. It simply means context is everything. So therefore, if I say the low back, I need to say the low back while walking, or the low back while running, or the low back while throwing, or the low back while hitting, or the low back while picking up my granddaughter, or the low back working in a factory moving boxes from the right to the left, or the low back reaching, or the low back. I have to always say, I just can't say apart and go, well, we'll understand the biomechanics of that, because we have to say, well, during what? The low back during sitting, the low back during, you get it. And so when we look at that, sometimes we start with what I call the most difficult one to biomechanically understand it, and also a common one with respect to low back pain, and that is understanding the biomechanics of the low back during walking. Now, strangely enough, when I got out of PT school, I saw a ton of patients, and a lot of them related, either they felt that walking caused their pain, or walking surely made it worse, or running. And therefore, I kind of had to scratch my head and go, well, I probably should know a little bit about walking, but more importantly, I probably should know a little bit about the biomechanics of the low back during walking. And I'd like to give you kind of a quick overview, because I think once we appreciate that, we can really understand why the low back are the crossroads of the body. Now, biomechanically speaking, another thing that we're going to emphasize, and Henry wanted to come in and say hi, that's okay. Yeah, he loves to come to webinars because he knows he's going to be able to see a lot of cool people out there who really care. So go boy, sweetie. That in the foot, we have a thing called the subtalar joint. We call it a torque converter. And that's always been intriguing to me, but all we're saying is that when my foot goes side to side, it converts that torque into rotational motion upstairs into the lower leg, the femur, and of course the pelvis and the low back. We also now believe that the lumbar spine is a torque converter. And when we understand the relationships of the vertebrae and how the facets are designed, that'll make sense. But the torque conversion is from rotational motion to rotational motion. So it converts rotation motion that's occurring in the trunk and in the shoulders into rotational motion down in the hips and knees and feet, and vice versa. Really important to understand that. The importance of the transverse plane with the low back. So before we go kind of too deep with that, let's simply just talk about what happens when somebody walks. And I'll kind of cheat here by having my pelvis. And I have a pelvis here, a couple femurs that have been chopped off, got a little sacrum going on here, and I got L5 and L4. So what I do to cheat many times, I'll take the anatomical part and I'll kind of do the thing, whether I'm swinging a golf club or walking, or well, it doesn't matter what I'm doing. I kind of go, okay, what's going on there? What is the bone, the pelvis doing? What is maybe L5 doing? What are the hips doing? What's the thoracic spine doing? And when we walk, it's quite fascinating because our foot hits the ground, and if you've listened to any of our foot webinars or information on the foot, we realize that's a fascinating thing in itself, but that torque converter of the subtalar joint creates rotation up into the hip, which allows the hip to internally rotate. We also, when our foot hits the ground, we get this motion going on at the knee that also absorbs shock called flexion, a little bit of abduction, and of course, because of the torque converter of the subtalar joint, internal rotation. Gravity and ground reaction force itself creates hip flexion as soon as my foot hits the ground and creates hip adduction. So my foot hits the ground, my butt kind of goes to that side of the body in order to load, in order to I can explode. And so we get flexion, adduction, internal rotation of the hip. What's intriguing is we got to look then at what the pelvis is doing. The first thing I do is I want to know just what the pelvis is doing in space, not what is the relative motion of the joint of L5-S1 or the sacroiliac joints. I'd like to know what in the world is the pelvis doing. And in gait, what the pelvis does is when the foot hits the ground, it rotates to the opposite side. We can all feel and see that. If I start here and then just take a step forward, my pelvis is rotating to the left. Easy to see. Put your hands on your hip, let the backbone slip. You can do that and you can feel that, see that. It's really easy to sense. In the sagittal plane, if everything's working well, I'm going from this anteriorly rotated position of the pelvis. In swing phase, I posteriorly rotate, not to a posteriorly rotated position, but I go through posterior rotation, and then when my foot hits the ground, gravity, ground reaction force, mass moment take over, I all of a sudden have anterior rotation of the pelvis. And in the frontal plane, as indicated, when that foot hits the ground, we get this adduction of the hip. This foot's way behind, so this part of the pelvis drops down, and we get a rotation of the pelvis in the frontal plane to the left. In the frontal plane called lateral flexion to the left. Easy to see, easy to feel. So I get that going on, rotation to the left, I get lateral flexion to the left, and I get anterior rotation of the pelvis. Good to know. I need to know what happens when the right foot hits the ground, and I need to know what happens when the left foot hits the ground. Obviously, the left foot would be the mirror image of what we just described. And so now we have the next question. If we're talking specifically about L5-S1, what is L5 doing? Well, I can kind of go to the punchline real quick and make this simple on all of us. It does the exact same thing the pelvis does. You're going, if it does the exact same thing, then there's no motion at L5 and S1. Correct. It does the exact same thing except not as much and a little bit delayed, because gait is not only dominated by obviously what the arms are doing in the transverse plane, but it's dominated by gravity, ground reaction force, mass and momentum, and by what the legs are doing. And so we know that when we do this, that the pelvis does these three things, but we also know L5 does the exact same thing. L5, if I put a marker on it, and they've done a ton of research on this, and this is all confirmed by research, is that as soon as the foot hits the ground, L5 anteriorly rotates. As soon as the right foot hits the ground, L5 laterally flexes to the left. As soon as the foot hits the ground, L5 rotates to the left. And you go, well, that's the same thing the pelvis did, yeah? But if I put markers on both, the pelvis is going to go a little further and a little faster. Now we got to know our relative motion. So if I have in the sagittal plane, the pelvis doing this, but L5 doing the same thing, but not as much, obviously I'm getting extension. If I have lateral flexion of the pelvis to the left and lateral flexion of L5 to the left, but not as much, I'm going to exaggerate the not as much here, is obviously you have lateral flexion to the right going on. And if I have rotation of the pelvis to the left, but I have rotation of L5 to the left, but not as much, we're getting, as we describe it by the superior bone on the inferior bone, we're getting right rotation. Even though both bones are rotating to the left, we're getting right rotation. Now that's hugely significant from the bottom up, and even more significant and bringing it all together from the top down when we walk. And therefore, if we kind of take a look at just the facets, and I think if I can get Brian to sneak in on this a little bit, you can see the lumbar facets are designed in, if you looked at them, you say, well, they look like they're kind of actually in the frontal plane here and kind of pretty vertical. And it looks like, wow, the only motion that's not going to occur at that exact joint, in other words, relative motion, is rotation. Research will say, well, you get maybe a degree or two. That's correct. There's very little. It's designed to have huge frontal plane motion and huge sagittal plane motion at L5S1, but no rotation, very minimal. Why? To convert the rotation that happens here to the rotation we need to have happen down here, and vice versa. Whoa, wow. That's big time. Because when we understand the kinematics, arthro and osteokinematics, and the neurology of the lumbar spine, we go, that's one of the most fascinating things I've ever seen. Because if we think about what we just said, and we ask ourselves a simple question, if I just ask myself, relative to the right lumbosacral facet and the left lumbosacral facet, what happens when I walk based on what we just talked about, we should be able to figure that out. So let's look at, first of all, the sagittal plane. In the sagittal plane, if I have the sacral facets here, which are oriented this way, we have the lumbar facets then that are oriented this way, then when I take a step and I anteriorly rotate, and you then said, hey, wait a minute, anterior rotation here, but not as much here extension, you know that extension creates a little bit of what we call compression, good compression of L5 and S1 on both sides. Got it. However, when we take a walk with my right foot hitting the ground and I lateral flex my pelvis and L5 to the left, but L5 doesn't go as far, you can see that because it doesn't go as far, there's a gapping on the left side, and there's a compression because of right lateral flexion on the right side. Interesting. When the right foot hits the ground in the frontal plane, the right facet of L5S1 takes on a little more stress, so to speak. And in the transverse plane, we have this phenomenon where the pelvis goes to the left, L5 goes to the left, but we have relative rotation to the right. That's when we need to look at our facets and go, wait a minute, if this bone is relatively rotating to the right, I can see on this right side that's going to create a gap, but on this left side, I can see that if it's going to rotate to the right, it's going to get compression. Now, it's not this bone rotating to the right, it's they're both rotating to the left, but this one going faster. Therefore, we get compression on the left side in the transverse plane. When you think about it, what comes to my mind is a miracle, genius, unbelievable. To have a body that has all this upper stuff hooked on to all this lower stuff by just this bone called L5S1 and create that kind of relationship where just with walking, not one side takes the hit at any one, it takes all three planes of the hit. It's like beyond genius. And so it's like if everything's working right, and we're going to say that every once in a while, if everything's working right, then I get a little bit of that compression, get everything ready to rock and roll. I get relative compression in the frontal plane on the right, and I get transverse plane compression on the left. When I then take the step, all that is relieved. My low back can breathe for a little bit, kind of goes into a cycle of, that's good, and then let's go back to work. And as soon as it hits the ground, the left low back says, I'm going to go in the frontal plane, right, you go to work in the transverse plane, sagittal plane, let's kind of lock it up a little bit to make us really stable, and help us convert the torque. Because what's happening is the pelvis is doing something predominantly in the transverse plane. You know my arms are creating predominantly transverse plane motion of the trunk. And therefore, we got to ask ourselves, what in the world is that motion in the transverse plane at the feet, knees, and hips doing below, and that same motion above? And the answer is creating powerful transverse plane motion to facilitate all the muscles, again, not only in the sagittal and the frontal, but in the transverse plane to give us the type of stability. Stability in AFS is not the lack of motion, it's the control of that rotary motion or any plane of motion in order to facilitate the task at hand. And when we understand gait is a transverse plane thingamabob. In other words, I don't walk in the sagittal plane. My pelvis doesn't just go in the sagittal plane, and my legs just don't go in the sagittal plane, and my body just doesn't go in the sagittal plane. I go, hey, subtalar joint, hips, let's go transverse plane. Hey, arms, go opposite. Let's go transverse plane. Let's take a walk and efficiently get to where we want to go. While that's happening, we need to know what the low back is doing. Now, we just kind of touched the surface on that. And you might say, well, that was kind of a deep surface. especially if we haven't heard it before. But as we understand what's happening in all three planes of motion and understand what's happening from the shoulders and the thoracic spine down to the lumbar spine and the feet and the knees and the hips up to the lumbar spine, then we can start hypothesizing initially, potentially, who's causing the low back, the angst that it's suffering. And the answer, bad news, could be anything. Good news could be anything. And why I say good news is because if our understanding of this and this doesn't work, I have 1,000 other places to go to help somebody with the low back pain. I remember I was given some protocols back in the 70s, and it's kind of, if the protocol didn't work, if the extension exercises didn't work, if the flexion exercise didn't work, if the traction didn't work, if the massage and hot pack and everything didn't work, it was like, I'm not sure if I got anything else to offer you. Knowing that any part of the body during that time of that activity can cause dysfunction in the low back because it has to go through the low back is a primary culprit that I need to investigate, then all of a sudden my whole world opens up and I go, you know what? I have many opportunities to take advantage of understanding this biomechanical chain reaction, but more importantly, giving you an opportunity to show me, is it your big toe that's causing the low back problem? Is it something at your ankle or subtalar joint or mid-tarsal joint? Is it any plane of motion of the hip? Any plane of the motion of the hip can shut down other planes, and you can already sense the importance of hip rotation for a healthy back and the importance of thoracic rotation and frontal plane motion for a healthy back. And so, do we need to look at the shoulders and the thoracic spine and the hips and the knees and the feet with anybody who comes in with low back pain? Certainly. We need to look at that if we want to prevent low back pain. And of course, we need to look at that if we understand the power of the core to allow somebody to perform any activity better, knowing that everything's going to go through the low back. So again, the fun thing about webinars is we can give you a little bit of information. The frustrating thing about a webinar is there's about 5 to 6 hours more that I'd like to talk to you about relative to the biomechanics and go into biomechanics. So let's say the golf swing or bowling or throwing, or again, most important thing, lifting my granddaughter off the floor, working in a factory, because they're different. We have to understand what's happening there. But with a webinar course, we don't have time. But I would like to take advantage of what you know to say, well, now that we kind of know that, that's the truth, so to speak, let's take a look at our strategies based on the truth of human function. Because all of a sudden, it's going to open a whole new opportunity for us to help people with that thing that just has destroyed their life called low back pain. So let's take a look at the strategies of AFS and see how we might apply that to some specific instances of low back pain. This is when evidence-based and science-based principles take over to allow us to understand the opportunity that we have to give that patient our best shot at alleviating their back pain. Now, here's the ultimate goal of AFS. If you come in and say, hey, I do this activity and this is what's causing my low back pain, our goal is to find out what caused that. Again, very little time is it from the low back, and solve those problems, allow them to go back to do the same thing with no low back pain. Now, a lot of us are able to kind of say, well, don't walk as much, or let's see if we get it to feel better, or let's calm everything down, or why don't you stop your running, or don't swing the club as hard, or maybe you can't work in the factory anymore and lift. Those are kind of easy things to do, but that's not the goal of AFS. The goal of AFS is to identify context dependent, what activity are we talking about, or activities, what part of the body are we talking about, and who do we think is picking on that part of the body? Now, knowing that any part of the body can pick on the low back, because it doesn't matter what part of the body moves, it influences the low back, we have a multitude of opportunities. But we have to start out with, so what should be in our brain? What should be our thought process? Again, you can tell in AFS we don't really appreciate what we'd call protocols. If they have this pain, try that exercise, try that modality, that we would say, nah, that's not good enough. As professionals of human movement, we don't think we're giving our patients our best. We would rather watch them move and then go, this is going to be easier than I thought. You lack a lot of ankle dorsiflexion on that side. Yeah, I sprained it a couple years ago, and watching you walk, I can see that that lack of dorsiflexion, bring that pelvis back hard, and during that phase, you're supposed to have a little bit of pressure, but now you're getting too much pressure. That's why you have your right low back pain. Let's take care of the ankle. Let's integrate it into the hip and the pelvis and into the low back, and let's get you back to walking without any pain and discomfort. Now, it's on the surface you go, well, it's not that easy. Well, as the more you know about chain reaction biomechanics, the easier it gets. However, you have to have a structure to say, okay, what do I need to understand in order to come up with the optimal environment to create the chain reactions that this person needs in order to get rid of the low back pain? And again, it's context dependent. So we rely on saying, here's the truth. If this is the truth, which is undeniable truth, based on thousands and thousands and thousands of reams of research, and therefore here's our strategies, and this is what the techniques look like. What's exciting to me is most of those techniques look nothing like what I learned in school. Now, it doesn't mean some of those what we might call traditional, relatively non-functional exercises aren't good. It's just they're not going to solve the problem of treating the cause to let the person get back to the activity that they want to get back to. That's their goal. I want to pick up my granddaughter, and I don't want to have the fear of having low back pain when I do that. Gotcha. I'm glad you came to us because we're going to try to figure that out. So when we do that, we go back to our, what we call our functional movement spectrum, which is all the principles of truth, which are undeniable. And we put at the top, in this case, walking in reference to the low back. So we're saying walking and more specifically lumbar spine. Okay, context dependent. This is helping me. And what first thing we do is we say, well, when we need to understand that, what is the person doing? What environment are they in? Are they hooked to a machine? Are they standing on something unstable? No, it's a natural environment. So we're going to say, we're probably going to use natural environments when we assess and train them. Is gravity and ground reaction force have anything to do with this? It has everything to do with it. And therefore, we don't want to confuse it much. Understanding that, yeah, there's a place for what we call horizontal therapy, laying back and on your side and on your belly for low back pain. If we're going to solve the problem of walking, which is an upright function, we're going to have to use gravity and ground reaction force to our benefit in order to solve the problem. So most of what we're going to be doing for this person will be in an upright posture. Mass and momentum. Well, wait a minute. What do you mean by that? Well, walking is all about mass and momentum. Losing my balance, grabbing my balance, taking advantage of that mass and momentum, and moving forward. Therefore, if walking involves mass and momentum, my rehab and my strategy of testing this person must involve mass and momentum. So I can't be on a table. I can't have the lack of motion. I can't try to just hold still. I got to get some motion going on here, and I got to see how the body deals with that motion in this particular context. This is kind of the physics of it all. Then we go, well, motion. Motion at the low back is in 3D. And even though there's little relative motion in the transverse plane, believe it or not, our goal is to get real motion, real bone motion, even more dominant in the transverse plane. That's kind of bothers some people at first because they say, well, I was taught when somebody has a low back incident that we teach them not to laterally flex and rotate. What we should have said, we need to get them to laterally flex throughout their body where they should, and we need to get them to rotate throughout their body where they should, so they don't have to abnormally rotate and laterally flex at the low back. And in fact, we need to facilitate that even more. So we have to concentrate all the time when we're dealing with low back problem in three-dimensionality. We can't just say, well, this is a sagittal plane problem or a frontal plane. It's impossible. So we have to think 3D. This is probably the weakest link for me over the last 46 years. What are the chain reaction biomechanics of that activity? So if I go from walking to swinging a golf club, when I take this golf club back, what's happening at my low back? Well, I need to know what's happening at my feet, my knees and my hips, and my thoracic spine, and my shoulders and my neck in order to answer that question. I can't just look at the low back and go, well, I think this is kind of what's happening at L5S1. So we need, as a profession, to be better in chain reaction biomechanics than anybody else in the world. Strangely, that's why we've been teaching chain reaction biomechanics for 46 years. This is a big one. In fact, when I was invited to give a talk one time at the challenge of the lumbar spine, the person that kind of proposed an alternative treatment to what I was going to describe as a functional context-dependent treatment. Basically talked about trying to limit rotation, try to limit lumbar motion, try to find lumbar neutral, try to kind of get on all fours and try to hold this and do co-contraction, and a lot of things that just Pooh Bear would go back and go, it just makes no sense to me. I don't think that's going to allow me to walk better with my wife. And so I don't think Pooh Bear is married, so he would say to walk with my buddies in the woods. So we would say, what's the goal relative to proprioceptors? I'll give you a hint. Talk to the low back, and the low back would say, turn on as many of my friends properly as you can, and you're going to take tremendous amount of stress off me. Well, excuse me, what would you say? Understand that when things are working well and a lot of motions are turning on proprioceptors and the proprioceptors are turning on muscles, that muscle control throughout the body creates very little stress at me, the low back would say. Therefore, your goal is to understand in that context-dependent activity how to turn on as many proprioceptors as possible. Well, when you see some of the, what I'd call non-functional traditional stuff, we're actually turning 90% of the proprioceptors off. We're not even letting them help us. The number one tool I think that helps with any dysfunction, especially low back pain, the power of the proprioceptors, and at some point we'll go deeper into that. The joints are integrated. Yeah. And the lumbar spine would say, just open your eyes and see what's below me. I have an SI joint that has very little motion, but we still have to take in consideration. But I have two powerful hips that are designed to go through all three planes of motion. And when we assess them functionally, we see huge deficits in them many times with low back pain. So don't have to look too far many times. The low back would say, I'm an integrated joint. Look at those two hips first. And then it would say, just look upstairs to my high lumbar spine and mostly that buddy of mine, the thoracic spine. If nothing else, the lumbar spine would say, please, please, please stand your patient up and get an idea what their hips are doing in all three planes of motion, what their trunk is doing in all three planes of motion. Their body will start to give you hints why they're not doing it and they're forcing me to do it and causing the abnormal stress. And of course, we want the back to react to subconscious tasks. We don't want to have them go against the wall and say, now think about this, contract your stomach and hold this and then try to walk like that and take the stress off your low back. I think back in the 70s, our heart was in the right spot. I don't think our head was. In fact, I know our head wasn't in the right spot, because now that we know that, that's not only ridiculous, but it makes absolutely no sense from a scientific standpoint, a biomechanics standpoint, a neurological standpoint. Good news is, by the time the person got to the parking lot, they couldn't hold that, whatever they were trying to hold. And so it not only didn't work, they couldn't do it. So we have specificity. Now we go right up to, okay, we're talking about the specificity of the lumbar spine relative to walking now. It's going to be different when we change the activity. So wait a minute, do I need to know the biomechanics of just about any activity that the patient says they think may be contributing to the low back pain? Yeah, that's a tough one. It's a whole new thought process. It's like, for some of us who went to school for years, we go, well, we didn't learn that. But I'm supposed to be a doctor of human movement, and we go, whoa, that's a big chunk of things I didn't learn. If I'm supposed to be a movement scientist and I don't understand the movement of a specific activity at a specific joint, then we probably really need to say, you know what? I always want to give my clients and patients the best. I'm going to go to work. I'm going to learn my chain reaction biomechanics, and I'm going to understand this. So we understand the specificity of the transformational zones of walking, what's happening in the transformational zones of walking. And then, of course, we have to understand the mobility and stability of all joints as it relates to the lumbar spine, and the lumbar spine mobility and stability that we're after. Again, our hearts were in the right spot when we realized motion at the low back was destroying either the disc or beating up the facet or chewing on the ligaments or putting an abnormal stress on the muscles. And therefore we said, boy, if we could just not have them do that, maybe it'll feel better. No, not have them do the abnormal stress. We have to find out who's causing that and then create an environment where they do have the normal stress, which many times creates more motion of the joints and better relative motion, less transverse plane relative motion and more frontal and sagittal plane relative motion at the right time. And therefore, the big thing we think with low back is to give this person an opportunity to share with us, hey, here's what's going on. In other words, I appreciate you looking at me, and I just got done telling you that it hurts when I walk, and you just took me through a movement sequence that you called 3D maps. I don't know what I would call it, but it's kind of like it gave me the opportunity to show you even certain movements that cause some pain. And then you put me in this position that looks a lot like walking, with the left foot forward and with the right foot forward, and you had me do some different things in different planes of motion. They may not say planes of motion. They go, I think you're onto something. The last person I went to, they didn't really let me show them what I can and can't do. They didn't look for my successes. They didn't look for potentially the cause. Again, they're not going to articulate it that way, but their eyes will tell you that. So we want to always create an environment where we're encouraging them based on building upon the success that they have, not to find out what parts of their body are just no good and say, well, we're in trouble there. No, here's where your successes are. Let's build upon it. Empower them with saying, listen, anything that causes discomfort that you have, you need to let us know, because that's a big piece of the puzzle. And that's a big, big, big consideration, because now they feel they're in control. Plus, when we go to work and create those chain reactions in the clinic and facilitate the appropriate exercises, because they're not going to be using equipment, they will be upright, they will be exercise designed to immediately take away the pain and treat the cause, they're going to really feel empowered, because they're going to say, hey, wait a minute, I can handle this at home. I won't need you at home. I think I can get even better at home. Yes, you can. I'd still like you to sneak back so we can continue to get you better, and then hopefully create an opportunity for your body to totally prevent this for the rest of your life. But yeah, my goal is to empower you. And the biggest thing you're going to find with applied functional science and the strategies here is that you're going to engage them, because they're going to be doing things they know are the things that ultimately cause their low back dysfunction, and therefore they're immediately going to have this like, wow. So an extreme example, I come to you with low back pain with my golf swing, and at no time during the evaluation do you take me through any movements that look like golf. You immediately lay me down, or have me do things on the ground, or have me do things holding my tummy on my back, and you'd go, I thought I told them my back hurts when I play golf, but maybe that's what we do first. We do something that has absolutely nothing done with golf. No, we go right to understanding the potential causes of the dysfunction through manipulating and understanding and facilitating our strategies, because now we have a multitude of strategies to say, I think we can get at this. Now, going deeper into the lumbar spine, an obvious strategy is, if I ask this part of the body, who's upsetting you? It would say, well, you don't have to look too far. Please look at my two hips, and please look at my thoracic spine. But then it would say, but if you're looking at my hips, knowing that we're walking, you're going to have to look at what my feet are doing. And if you're looking at my thoracic spine, knowing that we're walking, you're going to have to know what my shoulders and my upper extremities are doing. So I go, look at the low back, says, I really need to know the chain reaction biomechanics of everybody, really. Yeah, and the low back would go, yeah, that's true, but I want you to treat the cause of my dysfunction. I don't want you to just temporarily make me feel better or create a little distraction and take a little stress off. I want you to understand the cause, because I would really appreciate if you would take care of the cause. While I have this on my hand, again, it's the most obvious is, I wonder why the low back was designed to have no relative transverse plane motion, but I wonder why this L5 is so nicely articulated with S1, and I wonder why S1 is so nicely kind of bound between these two pelvis. I wonder why this talks so directly to the hips, and I wonder why the good Lord gave me so much triplane motion of the hips. The answer is, we got to have the hip mobility and stability, especially in the transverse plane, so this torque converter can talk to the thoracic spine and get it to work better the transverse plane, and vice versa. Immediately you can see a strategy as well. If either the hips or the thoracic spine doesn't have good rotation, we're going to have a big problem with a lot of activities, definitely walking, but probably almost any activity. Bingo. So if nothing else, a good strategy initially would be, well, let's just look at the transverse plane motion of the feet and hips and thoracic spine and shoulders. Because you're going to find a lot of evidence of what's been going on in that person's body that's causing the abnormal relative motion in the low back. When we walk, we're still going to walk, but if the thoracic spine isn't giving us the motion in the transverse plane, and if the hips aren't giving us the motion, it's going to go somewhere. It's going to go to the crossroads of the body. And that's where the low back rolls its eyes and goes, there it goes. I'm that low back pain again. But I appreciate seeing you, and I appreciate your kindness, and I appreciate more than that, your dedication and understanding to appreciate the chain reaction biomechanics and understanding your applied functional science so you can have these powerful strategies to take care of me. So over the last 46 years, how many times have I heard this one? I was just reaching for something and I've done it 1,000 times before and my back went out. And you go, well, first of all, I'm sorry, because we know how painful that is. And we know many times it then turns into spasm and this vicious cycle going on. But immediately, what we need to be thinking of is, I wonder what caused that. And the cause was not reaching for something. They just gave you a huge hint. I've done it 1,000,000 times before, but this time my back went out. We used to kind of go, well, during that you were kind of laterally flexing and you were rotating, so let's never do that again. Not a good strategy. Especially when the most powerful pickup movement for the low back. If you ask the low back, what's the most powerful pickup movement that you can do to protect yourself? It would say, I need you to rotate as much as you can into that hip and foot and thoracic spine. I need you to flex as much as you can, and I need you to laterally flex as much as you can in order to load your foot, your hips, your thoracic spine, and there's very little load on me. Got it. Kind of counterintuitive to what we were taught of teaching people to kind of artificially lift and keep everything in the sagittal plane and holding your pelvic tilt and doing this. Watch anybody that really has to be efficient at picking things up, especially like my garbage man. He will pick it up and use his whole chain reaction, and he'll do it over and over and over again without any low back pain because he's turning on motion in the joints where they should be turned on in all three planes of motion, and the low back itself says, I'm not taking the hit at all. But in some cases, in a lot of cases, like when we sit a lot during the day, when we do not know how to create mobility and stability in our body in three planes of motion, we do not know how to facilitate a three-dimensional reaction of our feet and our hips and our thoracic spine and our shoulders, where the facet joints themselves get what my scientific term for that is gunky. So for instance, let's say I put my right shoulder in a sling for about 2 to 3 weeks. Well, and all of a sudden I took it out of the sling and I did something that's quite normal for me, and that is maybe throw a ball. Well, you can already feel the pain. It's like if I took my hand and immediately took it out of the sling and did this, wow, knowing what that capsule of that shoulder, it got gunky during the time it was in the sling, you can almost feel the pain in your own shoulder going, I wouldn't suggest that. I would suggest you kind of mobilizing your shoulder in all three planes of motion, get in the transformational zones of throwing, make sure your hips and your feet and your thoracic spine are working, so when you throw, the shoulder does very little. But if I did do that, I would go, oh, my shoulder just went out. In other words, my back just went out. And when we hear that term, immediately we have to ask ourselves, what's going on throughout the day? Many times they can't, besides the activity of trying to pick that thing up, they can't necessarily relate the other things that are picking on their back. But what is going on when they're not getting the natural motion through the lumbar facets? Because there are a number of things probably going on that's making a facet not move the way it should move. Now, just with walking, we know it should move in the sagittal plane, it should move nicely in the frontal plane, and we should have relative minimal motion in the transverse, but the bone itself should have huge transverse plane motion. If that happens and it's symmetrical, that you're going to feed those facets good mobility and stability all the time, and they're not going to get gunked up. However, if I have just even a minimal tightness on my hip, I have just a little bit of lacking of ankle dorsiflexion, my big toe just doesn't dorsiflex as much as it should, I have just a pinch of thoracic kyphosis, I don't have good mobility with right rotation through the thoracic spine, I got a scapula that's kind of gunkied, and anytime I do things, instead of going through the scapula and through the thoracic spine, it abnormally goes through the low back, and it causes part of the low back to do too much and part of the low back not to do anything and get gunky. And therefore, that gunky facet, that gunky part, if now I do something that says, I know you're that way, but I'm going to do something that's very natural and normal, that I'm going to need you to then lengthen, to move in the sagittal plane and the frontal plane. And when it does that for the first time in a long time, all of a sudden you actually feel a rip. If you've ever experienced it, you actually can feel it. It's like, oh, crap, there it is. Not good. And so we have to have huge strategies to say, I wonder what caused that. And it wasn't the lifting episode. It was, what do you like to do? Let's first of all look at you in the context of just global human movement with 3D maps. Let's boil it down to, do you walk a lot? Yeah, let's look what your back does when you sit. So we have to look at the biomechanics of what your back, thoracic spine, and hips do during sitting. What else do you like to do? And you go, we're going to figure this out. We're going to figure out why your spine, why your facets aren't getting the normal mobility that they need, and they get gunked up, and then when you do a thing that's normal for you, it causes that acute low back episode. Those are fun, because those are life-changing for patients. Because that's something they'll say, and it happened last year. And it happened 2 years ago. And it happened. And I had therapy and I was better for a while. And for 46 years, I've heard that song over and over again. I don't want to hear that song. I want to look my patient dead in the eye and go, together you and I are going to try to figure this out. And with the strategies and principles of applied functional science, we've been able to do a much, much, much better job of figuring out what's causing the gunkiness in parts of their low back, and then making sure that that doesn't gunk up and making sure that stays as healthy as possible. Now, some of the traditional, and I want to be careful as I say this, because sometimes traditional is okay, but when I say traditional low back exercises, it's kind of like go back into your books and look at low back pain and see some of the things where you're laying down and you kind of need a chest and you're doing extension and you're doing Williams flexion and you're on all fours and you're pointing like a pointer dog and you're putting your back against the wall and you're trying to contract and you're laying down on a blood pressure cuff and you're kind of, as I facetiously say, don't take offense at this, farting into a blood pressure cuff. When you look at all those, you go, are those treating the problem that I want here? And years ago, some studies were done where they said, well, you know, if there's abnormal motion, and again, they were talking about relative motion of the spine, that relative motion is going to beat up the disc, and that's going to be the precursor to degenerative disc disease. So the strategy back then was, well, if we limit the amount of motion, obviously that's going to limit the beating up of the disc itself, and we're going to limit the degenerative disc disease. Well, here's what they should have said. If we limit the amount of abnormal relative motion, then that's what will happen. However, if we take a strategy where we're going to try to find, and back then we called it lumbar neutral, that we wanted to keep the lumbar spine as neutral as possible so that it wasn't an aggravation between L5-S1 or L4-L5 to chew up the disc, we would then say, boy, if we could just keep everything neutralized in the sagittal plane, don't flex too much, don't extend too much, neutralize in the frontal plane, and even to the point where some of the experts were saying, and I don't want no transverse plane motion. Well, as soon as you say that, you can't walk. If you said no transverse plane motion in my back, I'd go, okay, we're in trouble. Well, you kind of can walk, because if I kept everything in sync and I walk like this, where I kept my transverse plane in sync, I kept my sagittal plane in sync, and my frontal plane in sync, I'd have to walk like this. And I'm pretty sure Pooh Bear would really laugh at that one. And the good news is, if I did teach you how to do that, and you'd have no relative motion at the joint of L5-S1, by the time you got to the parking lot, The good news is you wouldn't be doing that anymore. So I say this a lot because I know our hearts were in the right spot. We were just trying to get rid of their pain. We were not asking a simple question. I wonder why they're getting abnormal motion at L5-S1. And that's where we as applied functional scientists come in, because that's our job. You already know where to start looking. And boy, I'll give you a hint, you're going to start looking at all three planes of motion of the thoracic spine, and you're going to look at all three planes of motion of the hips. And you know that one of the premises behind our 3D MAPS assessment is to do exactly that. Now, if you have kind of acute back pain, you say, well, I can't have them do those lunges and swing their arms all at the same time. No. You'd probably just do a little bit of lunging from the bottom up that's not going through the back. You probably do a little arm swing top down without the lunges that's not going through the back. Find out what planes of motion they are able to use bottom up and top down movement and go, wow, this is easier than I thought. Your ability to get through that hip into abduction is minimal. And therefore, you got what we call that really tight, abnormally functioning adductors. And therefore, when you walk, you're not getting good rotation through the hips. And therefore, when you walk, when those adductors hold that, you're getting bad rotation through your low back. So in this case, the simplicity of taking the adductors and mobilizing them in all three planes of motion and then teaching them how to strengthen it creates, in their mind's eye, a miracle. It's like, whoa, that's crazy. Within 2 or 3 treatments, I'm walking better, and my back pain's gone, and I don't think you did anything in my back. Well, we did. We treated your back through a chain reaction process. So with any type of disc problem, we have to, first of all, solve the spasm. We have to solve the pain, which, interesting enough, in applied functional science, we have a cool strategy for that that still holds water in functional. In other words, we do very little where we lay down. Very little, maybe traction to distraction. Not that it's bad. It's just that as soon as you do traction to distraction, you got to understand that are you solving the problem that they need when they stand up, and now when they do things, they're chewing up the disc? The answer would be no. I'm working on a symptom right now, and hopefully I can help create an environment where that disc feels a little better, but then I'm going to get them to move around for me to understand what's going on. One of the most fascinating things back in the 70s that I treated a little differently than most people, and it wasn't because I was any brighter than anybody. In fact, most of my friends will tell you definitely not there, even then or even now. But I would have a poo mentality where I remember seeing this lumbar spine, and I remember reading about spondylosis and then reading about spondylolisthesis. And it was interesting because I was taught that spondylosis is a abnormality, almost like what you'd call a stress fracture of the pars articularis, either on one or both sides. Obviously, there's an abnormal stress there. That's not designed to fracture. And then when that proceeded, many times, not all the times, but many times it proceeded into what we called a spondylolisthesis. All that is a spondylosis where the bone either shifts forward or shifts backwards. Now, more commonly than not, it shifts forward. And you get what's called an anterior spondylolisthesis. And then they taught us to say if it was a little bit, you'll call it a grade 1, a little bit more, grade 2, a little bit more than that, grade 3, a little bit more than that, like it's almost ready to fall off the segment below it. Now you got a grade 4, grade bad, they would call it, and now you're in trouble. Here's the problem. The lateral x-ray fooled us. And so when we put that x-ray up and we saw the sacrum, and then we saw L5 sliding down on the sacrum, we said, well, all we got to do is shift that sacrum back, make that slide more vertical, and the tendency for L5 to slide down and forward on S1 is going to be reduced significantly, and we now can retain some degree of integrity, even though we have a fracture of the pars articularis that gave it the integrity. Well, I can see where we thought that. Because it's staring us right in the eye. But if you go away from the 1 or 2 dimensional x-ray and you hand somebody a 3-dimensional model and you say, this is fascinating, we'll tell you why it's so fascinating, but if you are going to fracture this and this, and I did this with my grandson years ago, he was kind of a Lego nut. And I said, this is a Lego set, let's pretend. And this is a Lego called S1. This is a Lego called L5. And these Legos have a connection here, the joints. And he's very familiar with joints of Legos. And I said, but I want you to break the joint. I want you to make sure that L5 and S1 are no longer articulated quite nicely. In fact, I added one thing to it. I want this bone, L5, to be able to shift forward in S1. Without even thinking, he looked at it and he took the top Lego, rotated it to the right, and then he rotated it to the left, and he says, it's fractured now. I've solved what you wanted me to solve. And I go, whoa, wait a minute. What'd you just do? He goes, it's obvious. He says, if I would have taken this and gone back and forth, there's motion there. I can't create enough stress to create the fracture. If I go forward and back, I can't create the stress to create the fracture. This fracture is created by primarily transverse plane motion. Bells went off, whistles went off, a lot of things went off because I'm thinking, well, I'm just starting to look at the whole patient now, and it is very common that there's very little good functional hip rotation in these patients, very good rotation at the very little good rotation subtalar joint, and I'm really noticing very limited rotation in the thoracic spine. I wonder if that has anything to do with it. Not only does it have anything to do with it, I believe it's the primary cause of spondylolisthesis. I believe all three planes need to be considered, and obviously one plane influences the other two, and a little bit of extra flexion or kyphosis here does limit this, so now I can't just go after transverse plane motion to the thoracic spine without understanding I got to also build upon frontal plane motion and ultimately load and explode in the sagittal plane. But it's unusual now that we don't find significant deficits in the transverse plane at the hips and the thoracic spine. We solve the hips bottom up, the thoracic spine top down, then we put them back together, and not going to talk about the miracle of it all, but I think it's kind of a miracle when you understand the body's designed to heal itself, is that the stress goes away, their low back pain goes away, but more importantly, the cause of the spondylolisthesis has been now controlled. The progression of it is hopefully halted, and they're able to go back and do what they needed to do. I had a therapist from Chicago years ago call me. She was in charge of a gentleman who had low back pain, grade 2, grade 3 spondylolisthesis, played for, and I can't remember, that's not good when you get old, but I know it was either the Cubs or the White Sox. And she was his therapist, and she said he was sent out to California to go to a place to learn lumbar stabilization. And when he came back, he said, you know, I feel better, but I can't run, I can't throw, and I can't hit. They did nothing to train me to hit a ball better, to throw a ball better, or to run better, and that's what caused my problem playing baseball. I need to get back to baseball. And she called me up, she says, I'm seeing huge deficits, even more so now that he went there, that they taught him to just kind of co-contract things and try to keep everything stabilized. She says, he can barely move his hips into the transverse plane. Thoracic spine is, as she would say, using the word I love, gunk down. And she goes, I really have this sense that I need to get aggressive at the feet and at the hips and the thoracic spine and shoulders to give him the gift of the rotation back and see what happens. And I go, you're spot on. So she basically took him through progressions that this guy was taught in the facility out in California that were contraindicated. Now, what's contraindicated is abnormal relative motion at L5-S1. And abnormal relative motion at L5-S1 occurs because we don't have adequate rotation of the thoracic spine and the hips. So what's fun about this as we talk about it, it starts to take on not only some patterning, but some tremendous logic. And when things logically make sense to us, it's a lot better as opposed to somebody saying, trust me, here's the protocol, treat it. If they get better, Lord bless us all. If they don't, tell them good luck with the rest of their life. That's not what we as applied functional scientists desire to do. We want to understand this miracle called the human body so well that we can look at somebody and go, I'm very willing to make you feel better today, work on your symptoms, but my joy, my desire, my goal, my love is to understand what potentially is causing this, and together you and I are going to work on the causes. So when I see you a year from now, 3 years from now, 5 years from now, you go, you know what? I used to have that back episode almost every year. Hasn't happened. I wasn't able to do that for a number of years, and now I can with my grandkids. And that's what we know selfishly brings joy to us. I really appreciate you taking the time to spend time just to understand from a superficial kind of a 30,000 foot level of what we look at in applied functional science And hopefully you've gotten a couple little tidbits to go, this is something I'm going to think about. I really want to encourage you to continue to study your chain reaction biomechanics, to take advantage of a global human movement assessment called 3D maps, and then understanding how I go after those various joints and those planes of motion based on success through an understanding of what we call CAVs, or the localization of 3D maps. But mostly, I want to encourage you to continue to do what you're doing right now, and that is making yourself better, enhancing your understanding, enhancing your life, enhancing your ability, therefore, to take advantage of enhancing other people's lives. And on behalf of myself and the entire Gray Institute family, thank you so much for spending time with us discussing this huge challenge of the low back.
As I come before you here at the end of this webinar, what an amazing job Gary did delivering this type of information. To really understand the low back is to understand the rest of the body. To really hone in on that foot-ankle complex, the hips, the thoracic spine, and everything in between, because everything applies to the low back, because everything goes through the low back. And as you can imagine, this is an ongoing journey that we at Gray Institute don't believe that education ever stops. Education continues, and so does the applications, so that our benefactors, our patients, our clients, our athletes can reap the amazingness of this type of information. I just want to thank you for tuning into this webinar, because we know you care. We know you care about your patients, your clients, your athletes. We know you care about education. And to that, we simply want to say thank you for tuning into this webinar, but what you also do on a daily basis on enhancing the lives of those you serve.
Thanks for joining us here on the Gray Institute podcast. At Gray Institute, our goal is to do one thing the best we can, and that is to help you become the go-to movement professional. If you have a question for future podcasts or questions about anything Gray Institute offers, including education, live or online specializations, or mentorship, please email us at info@grayinstitute.com. Be sure to look for our next podcast coming soon. Have a great day.